Assalamu alaikum. Good morning to all my respected seniors and colleagues. Today's my topic of presentation is vertigo. Definition of vertigo: a feeling in which the external world seems to revolve around the individual or the individual itself seems to revolve around in space. To diagnose a vertigo is basically a symptom, not a disease. To diagnose a vertigo, detailed history is very important. And then clinical examination. There are few tests: head impulse test, test of SQ, vestibular test, and lab test, caloric test, electrosphygmography, optokinetic test, rotation test, galvanic test, posturography. Common causes of vertigo. Most common causes are peripheral and central, and rare other causes. Examples of central causes: stroke, vestibular migraine, tumor, multiple sclerosis. And peripheral, most common BPV, Meniere's disease, vestibular neuritis, labyrinthitis. Other cardiac diseases, side effect of medication, systemic diseases. Peripheral vestibular neuritis, Meniere's disease, characterized by vertigo, fluctuating hearing loss, tinnitus, sense of pressure in the involved ear. Vertigo is of sudden onset, lasts for few minutes to 24 hours. Benign paroxysmal positional vertigo, characterized by vertigo when the head is placed in a certain critical position. No hearing loss or other neurological symptom. Positional testing establishes the diagnosis and helps to differentiate it from positional vertigo of central origin. Disease is caused by a disorder of posterior semicircular canal. It has been demonstrated that otocanal debris consisting of crystal of calcium carbonate is released from degenerating macula of utricle and floats freely in the endolymph. When it settles on the capula of posterior canal in a critical head position, it causes displacement of capula and vertigo. The vertigo is fatigable on assuming the same position repeatedly due to dispersal of the otoconia, but can be induced again after a period of rest. Thus, typical history and dyshalpaic maneuver establishes the diagnosis. This is the maneuver in which the patient head is tilted towards one side 45 degree and hang it back and tilt the head 30 degree below the table and keep this position for 30 seconds and observe for vertigo. In benign paroxysmal vertigo, the nystagmus is horizontal and torsional, and then turn the head to opposite side at 45 degree and wait for 30 seconds. This is the dyshalpaic maneuver to diagnose the benign paroxysmal vertigo. The treatment of this maneuver is also benign paroxysmal vertigo is also a maneuver, which is a place maneuver. सर, इसमें जो एप्ले मैनूवर होता है, इसमें जो ओटोलिट्स होते हैं यूट्रिकल से नीचे फ्लोट कर जाते हैं सेमी सर्कुलर कैनाल में, तो इसमें एक ये मैनूवर है जिसमें हेड पोजीशन जिस तरह हमने डिसहल्पाइक में किया है उसी तरह करके जो सी है 45 से फिर फर्दर इसको हेड को नीचे डाउनवर्ड करते हैं. तो सर ये जो ओटोकोनिया जो ओटोलिथ है फिगर 1 में पॉइंट ए, ये यूट्रिकल से नीचे कैनाल में आया हुआ है. इसी रोटेशन में ये सर नेक्स्ट स्टेप में बी में सर ये 2 पोजीशन पे आएगा. इसको फर्दर सर 45 डिग्री अपोजिट साइड टर्न करेंगे तो 3rd पोजीशन में, और पिक्चर डी में ये सर 4th पोजीशन में है. और जब इसको दोबारा उठा के इसी तरह बिठाएंगे 30 सेकेंड तक, तो ये जाके दोबारा यूट्रिकल में जाएगा, जिसकी वजह से इसका वर्टाइगो सेटल होगा. और 80 to 90% सर विदाउट एनी मेडिकेशन सिंगल मैनोवर से ट्रीट होता है. एंड Third one is vestibular neuritis, characterized by severe vertigo of sudden onset with no cochlear symptom. Attack may last for a few days to 2 to 3 weeks. It is thought to occur due to virus that attack vestibular ganglion, most common herpes simplex virus. Management of acute attack is similar to that in Meniere disease. The disease is usually self-limiting. Labyrinthitis. Circumscribed labyrinthitis, it is a complication of chronic suppurative otitis media. Two types, serous labyrinthitis and purulent labyrinthitis. Serous is caused by trauma or infection adjacent to inner ear but without actual invasion. There is severe vertigo and sensory neural hearing loss. A partial or full recovery of inner ear function is possible if treated early. Purulent labyrinthitis is a complication of COSM. There is actual bacterial invasion of the inner ear with total loss of cochlear and vestibular function. Vertigo in this condition is due to acute vestibular failure. There is severe nausea and vomiting. Nystagmus is seen to the opposite side due to destruction of affected labyrinth. And in serous labyrinthitis, nystagmus is towards the affected ear. Fifth one is head trauma. Head injury may cause concussion of the labyrinth, complete disrupt of bony labyrinth or head nerve and or cause a perilimb fistula. Severe acoustic trauma such as that caused by an explosion can also disrupt the vestibular end organ and results in vertigo. And sixth one, perilimb fistula. In this condition, perilimb leak into the middle ear through oval or round window. It can follow as a complication of stapedectomy or ear surgery when stap is accidentally dislocated. It can also result from sudden pressure in the middle ear. Example, barotrauma, sea diving, forceful Valsalva maneuver, or raise intracranial pressure, weight lifting or vigorous cuffing. A perilimb fistula causes intermittent vertigo and fluctuating hearing loss, sometimes with tinnitus and sense of fullness in the ear. Syphilis of inner ear, both acquired and congenital, causes dizziness in addition to sensory neural hearing loss. Late congenital syphilis usually manifests between 8 and 20 years. Mimic Meniere disease with episode of acute vertigo, sensory neural hearing loss and tinnitus. Hanibert sign that is a positive fistula test in the presence of intact tympanic membrane is present in congenital syphilis. Neurosyphilis or tertiary acquired can cause central type of vestibular dysfunction. Acoustic neuroma. It has been classified in peripheral vestibular disorder as it arises from head nerve within the internal acoustic meatus. It causes only unsteadiness or vague sensation of motion. Severe episode of vertigo as seen in end organ disease is usually missing. Other tumor of temporal bone, glomus tumor, carcinoma of external or middle ear and secondary metastatic carcinomas destroy the labyrinth directly and causes vertigo. Central vestibular disorders. Vertebrobasilar insufficiency, a common cause of central vertigo in patients over the age of 50 years. There is transient decrease in blood flow. Common cause is atherosclerosis. Ischemia in these patients may also be precipitated by hypotension or neck movements when cervical osteophyte press on the vertebral arteries during rotation and extension of head. Vertigo is abrupt in onset, lasts several minutes and is associated with nausea and vomiting. Other neurological symptoms like visual disturbances, drop attack, diplopia, dysphagia, hemiparesis resulting from ischemia to other areas of brain may also accompany the vertigo. Some patients only complain of intermittent attacks of dizziness or vertigo on lateral rotation and extension of head. Posterior inferior cerebral artery syndrome, Wallenberg syndrome. Thrombosis of the posterior inferior cerebral artery cuts off blood supply to the lateral medullary area. There is violent vertigo along with diplopia, dysphagia, hoarseness, Horner syndrome, sensory loss on ipsilateral side of the face and contralateral side of the body and ataxia. There may be horizontal or rotatory nystagmus to the side of the lesion. Basilar migraine. Migraine is a vascular syndrome producing recurrent headaches with symptom-free interval. Headache is usually unilateral and of throbbing type. Basilar artery migraine produces occipital headache, visual disturbance, diplopia, and severe vertigo, which is abrupt and may last 5 to 60 minutes. Basilar migraine is common in adolescent girls with strong menstrual relationship and positive family history. Cerebellar diseases. Cerebellum may be affected by hemorrhage, infarction, infection, or tumors. Acute cerebellar disease may cause severe vertigo, vomiting, and ataxia simulating as acute peripheral labyrinthine disorder. Tumors are slow growing and produce classical features of cerebellar disease, that is, incoordination, pass pointing, dysdokinesia, rebound phenomena, and wide base gait. Multiple sclerosis. It is a demyelinating disease affecting young adults. Vertigo and dizziness are common complaints. There are other multiple neurological signs and symptoms. For example, blurring of vision, diplopia, dysarthria, paresthesia, and ataxia. Spontaneous nystagmus may be seen. Tumor of brain stem and floor of fourth ventricle. Gliomas, astrocytomas, cytomas may arise from pons and midbrain. Medulloblastoma, ependiomas, epidermoid cysts, or teratomas may arise from floor of fourth ventricle. These tumors cause other neurological signs and symptoms in addition to dizziness and vertigo. Positional vertigo and nystagmus may also be the presenting feature. CT scan and MRI are useful in their diagnosis. Epilepsy. Vertigo may occur as an aura in the temporal bone epilepsy. The history of seizure and unconscious following the aura may help in diagnosis. Sometimes vertigo is the only symptom of epilepsy and that may pose a difficult diagnostic problem. Electroencephalography may show abnormalities during the attack. Cervical vertigo. Vertigo may follow injuries of neck 7 to 10 days after accident. It is usually provoked with movement of the neck to the site of injury. Examination shows tenderness of neck, spasm of cervical muscle, and limitation of neck movements. X-ray shows loss of cervical lordosis. Exact mechanism of cervical vertigo is not known. It may be due to disrupted vestibulo-basilar circulation, involvement of sympathetic vertebral plexus, or alteration of tonic neck flexus. Other causes of vertigo. Ocular vertigo. Normally, balance is maintained by integrated information received from eyes, labyrinth, and somatosensory system. A mismatch of information from any of these organs causes vertigo, and in this case from the eyes. Ocular vertigo may occur in case of acute extraocular muscle paresis or high errors of refraction. Psychogenic vertigo. This diagnosis is suspected in patients suffering from emotional tension and anxiety. Often other symptoms of neurosis, for example, palpitation, breathlessness, fatigue, insomnia, profuse sweating, and tremors are also present. Symptoms of vertigo is often vague in the form of floating or swimming sensation or lightheadedness. There is no nystagmus or hearing loss. Vertigo is a symptom, not a disease, so effective management of vertigo involves treatment of underlying root cause. थैंक यू। अच्छा सर, इसमें ये तो सर लंबी चौड़ी है, इसमें सही तरह ना समझ नहीं आती। इसको बेसिकली जो डायग्नोज करने के लिए इजी होता है उसमें हम लोग हिस्ट्री सबसे इम्पॉर्टेंट होती है। इसमें टाइम ड्यूरेशन हमने पूछना होता है पेशेंट से कि कितने टाइम तक होता है। इसमें अगर रिकरेंट एपिसोडिक वर्टाइगो हो और वो लेस देन 1 मिनट हो तो वो सर मोस्ट कॉमनली बिनाइन प्रोग्रेसिमल वर्टाइगो होता है और वो ट्रिगर करता है नेक हेड मूवमेंट के साथ। इसको सर कंफर्म करने के लिए डिसल्पाइक जो मैनूवर था उसमें हम लोग एक्सरसाइज मैनूवर करवाते हैं, तो उसमें अगर निस्टेगमस सर हॉरिजेंटल और टॉर्जिनल निस्टेगमस हो तो फिर वो कंफर्म होता है कि बिनाइन प्रोग्रेसिमल वर्टाइगो है। उसकी ट्रीटमेंट सर फिर वो एप्लेस मैनूवर है। मोस्ट कॉमन सर ये BPV है सर। और अगर रिकरेंट हो, एपिसोडिक वर्टाइगो हो, वो मिनट्स टू आवर्स की अगर हिस्ट्री दे दे सर, तो फिर दो चीज़ें हो सकती हैं, मीनियर डिजीज़ हो सकती है या वेस्टिबुलर मिग्रेन हो सकता है सर। और मीनियर से वेस्टिबुलर मिग्रेन ज़्यादा कॉमन है। इन दोनों के सर साइन एंड सिम्टम तकरीबन सर सेम ही होते हैं। इनको हम डिफ्रेंशिएट करते हैं प्योर टोन आडियोमेट्री से। मीनियर डिजीज़ में हेयरिंग लॉस होगा, वेस्टिबुलर मिग्रेन में हेयरिंग लॉस नहीं होगा सर। और अगर सर कंटिन्यूस वर्टाइगो हो, नॉन रिमिटिंग वर्टाइगो हो, वो डेज टू वीक्स तक चले सर, तो फिर उसमें दो कंडीशंस हो सकती हैं, वेस्टिबुलर न्यूराइटिस हो सकता है या सर स्ट्रोक। इस कंडीशन में सर फिर हमें इमेजिंग की तरफ जाना पड़ता है। पहले उनमें सर हम लोग मैनुअर्स और प्योर टोन से डिफ्रेंशिएट कर सकते हैं। जब कंटिन्यूस वर्टाइगो हो, नॉन रिमिटिंग हो और वो डेज टू वीक्स हो, तो फिर उसमें सर वेस्टिबुलर न्यूराइटिस या स्ट्रोक में डिफ्रेंशिएट करने के लिए दो टेस्ट होते हैं सर। हेड इम्पल्स टेस्ट, उसमें पेशेंट को सर इस तरह बिठा के उसकी आइज़ को फ्रंट पे, उसे कहना है आगे नोज़ पे, एग्जामिनर के नोज़ पे फोकस रखना है। हेड को सर इस तरह रोटेट करते हैं राइट साइड पे और एकदम जर्क के साथ सेंटर में लाते हैं। जब उसमें सर्किट मूवमेंट होती है, वो एकदम सर आइज़ मूव करती हैं सेंटर की तरफ, तो ये पेरिफेरल की तरफ डिनोट करता है। ये वेस्टिबुलर न्यूराइटिस में होता है। अगर सर्किट मूव सर कोई सेंट्रल काज है, स्ट्रोक मोस्ट लाइकली। दूसरा सर टेस्ट, ये पेशेंट को फोकस फ्रंट पे करवाना होता है, एक आंख के आगे हाथ रख के फिर इस तरह हाथ को मूव करना होता है, इस आंख से फिर एकदम इस आंख पे आई मूवमेंट करती है। अगर टेस्ट ऑफ सिक्यू पॉजिटिव हो गया तो ये भी सेंट्रल, मोस्ट लाइकली सेंट्रल काजेस होते हैं। फिर हम लोग सर एमआरआई की तरफ जाते हैं। अदरवाइज एमआरआई की बाकी उनमें इतनी नीड नहीं पड़ती है हर वर्टाइगो केस में। ये सर मोस्ट कॉमन है, बीपीवी, मीनियर, वेस्टिबुलर मिग्रेन और वेस्टिबुलर न्यूराइटिस। वेस्टिबुलर न्यूराइटिस में ये होगा सर कि एक हफ्ता पहले उनको मोस्टली अपर रेस्पिरेटरी ट्रैक्ट इन्फेक्शन की हिस्ट्री होगी।